Atrial will contract, the tricuspid will close. It's actually very crucial to know the central venous pressure, and in this demonstration we will demonstrate how to take this reading. Actually here we have the inferior vena cava and superior vena cava, the blood coming from the whole body, and it will return back to the right atrium. Okay, after that it will go to the right ventricle, it will go to the pulmonary circulation, give the CO2 and get the oxygen, and coming back to the left atrium and the left ventricle, then it will be ejected with oxygenated blood. Now in this lecture actually we will concern about the pressure which is here in the right atrium, which is reflecting how much the fluid status in the body. What will happen? They will insert a line. This line will come and it will almost fix at the tip of the right atrium, and it will be connected to a transducer. Transducer will convert this biophysical activity of the blood volume here, amount of blood, and will make it as number and waves in the cardiac monitor. Central venous pressure or right atrial pressure. It will allow you to know the patient's response to the treatment. The normal central venous pressure 2 to 6 millimeter mercury for the adult. So here if we have a lot of fluids here, the pressure which will be in this room will be increased. If there is like heart failure, the heart cannot pump and eject the blood, there is accumulation of the fluids here, the central venous pressure will become high. If there is cardiac tamponade, it will be high. If there is pulmonary hypertension, this number will be high. Because there is accumulation of the blood in this area, it will be reflected by the transducer as numbers. If there is vasodilations, if there is less amount of fluids, this number will go down. The monitor will give me number and wave. Actually, it's really important to understand the basic for that wave, which is like this wave reflecting the pressure. So if I have like increasing here, increasing here, increasing here, it means there is increasing in the pressure. And now let's connect it to the changes happening during diastole and systole, what these waves are representing. Let's start by the A wave. Okay, so the A wave, it means the atrial contraction between the right atrium and the superior vena cava. There is no valve, so whatever here pressure happened here, it will be reflected in the superior vena cava, and it will be reflected to the monitor because there is no valve. Now the atrial will contract. When the atrial is contracting, the blood will be go to the right ventricle. Okay, and there will be like increasing in the pressure inside this room, inside the atrial. This one will be determined by a wave. So the machine will understand there is increasing in the pressure in the room, and that one is A. So A is right atrial contraction. Okay, what about the C wave? Once the right atrial contracted and finished the contraction, and now it's the turn for the left ventricle to contract. When left ventricle will contract, it will close the tricuspid valve. So the closure for this valve, it's like pushing the blood little bit, so it will be determined by the C wave. It will be determined by the C wave. After that, it will go down. What about the V? You remember that the blood did not stop to come from the inferior vena cava and superior vena cava to the right atrial. So the blood, when it's coming back, it will make increasing in the pressure, so it will make the V wave. So in summary, these waves reflecting the process for the systole. The atrial will contract, the tricuspid will close, and the blood will come back and fill the chamber. By the way, if my patient has femoral central venous line, so can I monitor the CVP? The answer is no, because that one is very far from the heart. Follow your institutional standards for adding or not to add heparin to the flush solution. Label the IV bag, indicate the date and the time you hang the fluids, and if you add heparin or no. This will help you to determine the time you need to change the system, because it should be changed after 96 hours or 4 days. Now prepare the system. Open the packaged pressure transducer kit with aseptic technique. Tightening the connections prevent air from entering the system and fluids leak. In this system, actually, I did not find any need to more tightening because it's already tightened. As a standard, you need to change the vent cap, remove it, and replace it with a new sterile one. In this system, no need to change the caps, and that one by manufacturer. Recommendations. Cover cannula. If we compare the two cover cannula, we will find this cover cannula, just loosening it, it will not be removed. So loosening, then reuse. No need to change it. But in this cover cannula, when you lose it, it will be removed. So you need to change it with the new cover cannula. Throw this, bring another one, then use it. Spike the outlet port of the IV solution with the pressure tubing. Here you can close the roller clamp as we use. Insert the IV bag into the pressure bag or device on the IV pool. Do not inflate the pressure bag. Priming the tube under pressure will increase the turbulence and may cause air bubbles to enter the tube. Now squeeze the drip chamber to fill the half. This will prevent the air bubble from entering the tube and allows the nurse to see that the solution is flowing when performing manual flush of the invasive line. With the use of pole mount, insert the transducer into a pole mount holder or the transducer plate. This one has two. I have to flush each one alone. Okay, so open from here. So I will flush this, remove the normal saline by the air port first. Okay, see here. So it's flushed. Now close to the air, close the stopcock, then continue to flush the patient side. You can see it all. Until it's flushed. See here. Now after we flush the first line, I will flush the second one. Same technique. I will open the roller. Okay. Then I will start to flush. I will flush first the air. So close to the patient, open to the air, flush. Okay, until there is flushing with normal saline. Close to the air, close the stopcock. If you are doing the double pressure or triple pressure transducer system, this step it will be repeat in each time. Now you need to inflate the 300 millimeter mercury because this one will give 1 to 3 ml flush per hour, and it will maintain the catheter patency and minimizing the clot formation. On bedside monitor, plug the pressure cable zeroing the transducer, leveling the transducer. Level the transducer's air fluids interface to the flippostatic axis whenever the patient's position changes. We need to make sure the transducer at the flippostatic point, which is the fourth intercostal space. The fourth intercostal space and in the mid-axillary level. With a sterile technique, connect end of the transducer tubing to the catheter port. Select central venous pressure. Okay, so it shows that it is CVP now. You can actually flush with normal saline. Turn the stopcock off to the patient ending of the tubing. Remove the non-vent cap from the stopcock, opening the stopcock to the air. Push and release the zero button on the bedside monitor. Observe the digital reading until it displays a value of 0. Place a new sterile injectable or non-injectable cap on the stopcock. Now, as I told you previously, in this model, no need to change the stopcock. This is from the manufacturer. Turn the stopcock so that it's open between the patient and the transducer. Now, observe the waveform. You need to check the IV pressure bag every 4 hours or as needed. Maintain it 300 mm mercury. You need to change the hemodynamic monitoring system, flush solution, pressure tubing, transducers, stopcocks, all every 96 hours. When I have to do zeroing, during initial setup, before insertion, after insertion, if disconnection occurs between the transducer and monitoring cable, if disconnection occurs between the monitor cable and monitor, and when the values obtained do not fit the clinical picture. Thank you for watching the video. See you in another skill.